Good morning, everybody. Thank you, as always, for joining us here. We're just taking our time, giving it a minute or so to let all of you join in. Hope everybody's having a great week and enjoying a great summer. We have a really wonderful presenter this morning to talk about an important topic to us in medicine. Before that, we do have a couple of updates for you. We're going to start with Dr. Ben Pinsky to talk more about variants. Dr. Pinsky, as always, thank you for being with us. I'll turn it over to you first.
Thank you, Errol, and good morning, everyone. I will give a brief update on the COVID-2 variants. As you know, the Delta variant is now the predominant variant in the United States, as well as in our Stanford patient population. It's shown here on the top line. It has a particular mutation in spike L452R that's shared also with our Epsilon variant, the California variant that we had circulating earlier this year. We've also seen some of these sublineages, so-called Delta Plus, which have an extra mutation, 417 to N, also in the spike. And there was recent media coverage of the Lambda variant. We have not yet seen that in our patient population, but it is in the United States now. So looking at our variant data, as you can see, Delta arose and came into our patient population in the beginning of May and has subsequently taken off, as you can see quite strikingly over the last several weeks, where now Delta in this L452R mutation accounts for about 90% of our genotyped cases. We have confirmed a subset of these by whole genome sequencing. And indeed, all these yellow bars, these samples are predominantly the Delta variant with a very small number of a different variant, different lineage that contains L452R called A2.5. We are no longer seeing the Epsilon variant, also known as the California variant, in our patient population. And you can see up here in the corner, I've listed our 7-day positivity rate, as you know, has been creeping upwards. We're close to about 3% at the moment overall, and our test volumes are also increasing. So that's our variant update for this week. I'm happy to take questions in the Q&A in the chat. Thank you.
Great, Dr. Pinsky, thanks so much for being with us and providing the updates regularly. We will have more updates, including regarding vaccination. We've been having a lot of questions about that. Dr. Bowman isn't with us today, but we'll make sure he's back with us next week and being able to provide more updates regarding vaccination and the logistics surrounding all those issues that will be coming up. So thanks so much. We purposely wanted to make updates not too busy this week because we have so much stuff to present. With our presenter, Dr. Randy Cron. Introducing Dr. Randy Cron will be Dr. David Lewis. I do want to briefly mention next week we have a topic of Grand Rounds called the title Racial Disparities in Healthcare and Health, together with one of our medicine residents, Dr. Mary Chandran, along with Dr. Kevin Schulman. And then the week after that, honoring Breastfeeding Month in August, we have Dr. Crow and also our resident, Chief Resident, Dr. Jessica Blessing. And then the following week, we'll be talking about COVID variants. So we have a lot of great topics coming up. We're really excited to be having more non-COVID topics along with the important COVID topics as well throughout the year. So that's wonderful. And then next, I'm going to turn it over to Dr. David Lewis. Dr. Lewis is going to introduce Dr. Cron. Dr. Lewis joins us from the Department of Pediatrics, and we're really lucky to have him with us to help us introduce and just be with us on the panelist side today. He's a professor of allergy and immunology. And I just want to say he, along with a number of our faculty, had recently reached out asking to have Dr. Cron come and speak. So really, I just want to say thank you, Dr. Lewis, for introducing Dr. Cron. And Dr. Cron, thank you for being with us. Dr. Lewis, I'll turn it over to you now.
Yeah, it's with great pleasure that I introduce Randy Cron for this Medicine Grand Rounds. Randy is the director and founder of the Pediatric Rheumatology Fellowship and is a professor at the Children's Hospital of Alabama and the Department of, he has many affiliations with the University of Alabama in Birmingham. And he did his training, MD, PhD training with Jeff Bluestone, who's now located up the hill at UCSF and familiar to many of you. And I was very fortunate to have Randy in the lab as a postdoc, where he did a little sojourn to learn a little human immunology before he went on after 1 year, I think, at Stanford as an instructor to bigger and better things. And in the last 20 years or so, he has really become a world's leader in research involving many aspects of inflammation, particularly in the context of macrophage activation syndrome and rheumatology, among many other topics that he's active in. So it's with great pleasure that I turn it over to Dr. Cron for this presentation.
All right, got the right screen?
Yeah.
Excellent.
That's good.
Well, thank you, Dave, and thanks to others who invited me graciously to speak to y'all. It's kind of a whirlwind, so I'll try to get through this as quick as I can. But the topic is the cytokine storm syndrome, which has been pretty popularized lately with the current coronavirus. So I can figure out how to advance my slides. All right, so I do have some disclosures that are relevant. So my interest in this, and I think kind of a good case to start with, was this 14-year-old girl, this is when I was in Philadelphia, who presented to us with a diagnosis of cytophagic histiocytic paniculitis, something I had not seen and hope to never see again. And this unfortunate girl had had fevers, high fevers every day of her life, and total body paniculitis and lipoatrophy, to the point that she made long distance runners seem morbidly obese in comparison. And she presented to us in clinic with belly pain and a big liver. And she was about the size of a 7-year-old at age 14. We figured either from chronic undertreated inflammation and or just chronic steroid use. When we saw her, she was really only receiving acupuncture. Seeing the word paniculitis, we started her on cyclosporin and glucocorticoids. She got a little bit better, but unfortunately she was back within a month, except this time admitted to the hospital. She presented again with belly pain, but quickly seized, became comatose, had inflammatory markers in her blood and her cerebral spinal fluid, became coagulopathic, pancytopenic, hyperferritinemic, you name it, and developed very, very quickly multi-system organ failure. So she was on multiple inotropes to support her heart. She had severe ARDS and very high vent settings. She was in renal failure, liver failure. She had pancreatitis. Her cell lines were all gone. She was bleeding from all her orifices. And for me, ultimately, she was probably the sickest kid that I've ever taken care of that essentially came out of the ICU unscathed. And here is pathology from her bone marrow from that hospitalization. And this is this activated macrophage or histiocyte engulfing multiple other cell types, one of the kind of hallmark features of many cytokine storms. This we got later. This was from 9 months of age, showing her nice fat cells, but infiltrated with all these lymphocytes that don't belong there. And there are these HLH or hemophagocytic lymphohistiocytosis criteria that have been updated in 2004. That were developed for a familial or genetic form of this disease. So you can come with a genetic diagnosis, which most infants don't unless they've had a family member maybe, but they have these 5 out of 8 clinical/laboratory criteria. And these are often very, too restrictive for many of the secondary forms that are not so genetically involved. And so, but she was so sick that she met these in spades, and in fact they're good to just kind of describe the disorder. So almost all these patients have fever, large spleen, and most of them have actually large livers, but that's not part of the criteria. Their cell lines go down. They consume fibrinogen. So fibrinogen will actually go up as a marker of inflammation, but then in the coagulopathic process it gets consumed, and the erythrocyte sedimentation rate can be largely driven up by hyperfibrinogenemia, but as it gets consumed, the erythrocyte sedimentation rate tends to fall. So a falling sed rate, particularly as the CRP is going up and they're clinically getting worse, is usually ominously bad sign. Hemophagocytosis, which is present in about 60% of patients. It's neither highly sensitive nor highly specific, but is part of a couple different groups of criteria. And then some of these are not timely at a lot of institutions, including absent or low natural killer cell function, elevated IL-2 receptor alpha chain or soluble CD25, but kind of shared by most all these conditions is this hyperferritinemia. And this is a relatively low cutoff of 500 nanograms per ml. It's definitely elevated, but many of these patients are in the tens or hundreds of thousands range. And they had called the oncologist first. This was back in 2004 because of their experience with HLH and a protocol to give them chemotherapy with etoposide. And they started her on that pathway, but she was getting worse. So etoposide, cyclosporin, steroids. And my colleague Ed Behrens, who was a fellow at the time, they called us eventually. And around this time, we had started using an IL-1 receptor antagonist, the drug anakinra, to treat children with systemic juvenile arthritis who had developed a cytokine storm called macrophage activation syndrome. And it seemed to work rather well for their disease. So we figured this was similar enough, and this girl was going to die. She was about as close to death as you get. And we talked with the family, talked with the team, and we started a relatively low dose of anakinra. And within 2 days, she woke from her coma. Within 6 days, she was out of the intensive care, and 2 weeks, she was out of the hospital. And it was really nothing short of miraculous, for me at least. And so the thought on the proposed pathophysiology of this disorder is if we just take a generic strength of your immune response on the y-axis, time along the x, and let's say you're a normal host, and you get infected, let's say influenza, your immune system should mount a response. Hopefully you begin to clear that pathogen. And then your immune system is actually hardwired to shut itself down, or we'd be one giant lymph node like an ALPS patient or an LPR mouse, for example. But what's thought to occur in many of these cytokine storms is that there is a defect in the perforin-mediated cytolytic pathway that's shared by both natural killer cells and cytotoxic CD8 T cells. And when they recognize their target cell and are incapable of lysing this infected antigen-presenting cell, they remain engaged and generate an inordinate amount of pro-inflammatory cytokines that are thought to lead to the multi-organ failure. And this was modeled very nicely in mice by Michael Jordan, not the basketball player, but the pediatric hemato-oncologist, when he was in Pippa Merrick's lab in Denver. And what Mike did was he took wild type or normal genetic mice and homozygous deficient, perforin deficient mice. And these mice, the perforin deficient mice, are perfectly fine in the mouse colony until something bad happens. In this case, infection with LCMV virus. Now, the wild type mice, the CD8 T cells will recognize the infected antigen presenting cell. They'll generate inflammatory cytokines, including interferon gamma, and they'll lyse these cells and shut down the viral life cycle through the perforin pathway, and they do fine. These mice uniformly die within 10 to 14 days. They can recognize the cell, they just can't kill it through that perforin pathway. And so this was very nice, but what Michael did, and one reason I think at some point everyone should read this paper, who's a physician or in the medical profession, is he blocked one of these pro-inflammatory cytokines, interferon gamma. And the mice don't clear the infection as well as the wild type mice, but they don't die. Similarly, if he blocked the CD8 T cells, again, they don't clear the infection that well, but they don't die. And so this really important concept of, although the virus here is the trigger, it's the immune system that's killing the host. And so in addition to perforin, there are several now, more than this list, of genes that are involved in the perforin-mediated cytolytic pathway. And if you're homozygous deficient in them, you will get familial HLH. And this is modeled here. So on the left here, we either have a cytotoxic CD8 T cell or a natural killer cell that share the same pathway. And perforin is actually preformed in cytolytic granules along with proteins like granzymes. And when they recognize their target cell, these cytolytic granules will traffic and polarize along this actin cytoskeleton to the immunologic synapse. And these other proteins, if you're deficient in RAB27A or syntaxin 11 or MUNC13.4, et cetera, are important in this process for docking and fusing, et cetera. So if you're deficient in any of them, you'll have a defect in killing. And the perforin gets released and then forms a channel or pore between these cells, allowing for delivery of granzymes, which then trigger apoptotic cell death of the target cell. And so we have this umbrella term now of cytokine storms. It's been around for a while, but we're trying to use it more of an umbrella term. These conditions are clearly not all the same, but they do share some features, including hyperferritinemia and often multi-organ failure. And we have what the rheumatologist will call a macrophage activation syndrome and adult onset still disease, for example, or systemic JIA. Various hematopoietic malignancies, leukemias and lymphomas can trigger cytokine storms or HLH, as can therapy for some of the refractory forms of these diseases, like CAR T-cell therapy can trigger cytokine release syndrome. There are the genetic ones we briefly touched on, Castleman's disease, Kawasaki's, and other vasculitides. And then there's a large Venn diagram of various infections, mostly intracellular pathogens, and very commonly members of the herpes virus family. So Epstein-Barr, CMV, HHV6, et cetera, as well as bad strains of influenza. And now some of us are also including subsets of patients with severe COVID-19 and this post-infectious multi-system inflammatory syndrome in children, or MIS-C. And so we have these rare genetic forms, which account for about 1 in 50,000 live births is the estimate. But these are much more common. Maybe 1 in 2 to 3,000 individuals will develop a cytokine storm later in life. And again, there are many rheumatologic conditions, particularly the autoinflammatory, systemic JA, adult onset stills. Lupus can do it. Certainly, it's probably the most common in adults. A huge slew of infections, including weird bugs like Ehrlichia and hemorrhagic fever viruses, but certainly influenza and the herpes virus. The herpes virus family members. And then again, malignancies. But we probably learned the most about some of these secondary forms, particularly MAS, from children with systemic juvenile idiopathic arthritis. This is the chronic arthritis of childhood. It's about 1 in 10,000 kids in this country who get the fever, the rash, the internal organ serositis, for example. And if you read the old textbooks, they'll tell you that about 7 to 10% of these children will develop macrophage activation syndrome. And these kids, their disease is, their flare of disease is very similar to some of the features of macrophage activation syndrome. So maybe, it's part of the disease and not necessarily a complication, but really just part of the disease pathogenesis. And so to explore that, Ed Behrens, when he was a fellow in Philadelphia at the time, got a hold of 16 bone marrow biopsy samples from children that we had diagnosed in the hospital with systemic JIA. And the reason we got bone marrows, particularly in these younger kids, is before you want to start throwing high-dose glucocorticoids at them, you want to make sure you're not treating leukemia, for example. And what Ed found, well, first of all, two of these patients are roughly what the textbooks would tell you. We were clinically astute enough to diagnose as having MAS when they presented with systemic JIA. But when the hematopathologist was asked to specifically look for hemophagocytosis, and this is important, so if you send lymph node or bone marrow or whatever to your hematopathologist, and you want to know about hemophagocytosis, specifically ask them to look for that. Maybe even do a soluble, a CD163 stain. Nevertheless, about half these kids had more hemophagocytosis than you would normally see on the marrow and/or overly activated macrophages. And the scary thing was that 2 of the 3 who had the worst looking marrows we had completely missed clinically as potentially having MAS. None of the controls had evidence of this. So we developed this concept that in addition to the 2 that we were smart enough to recognize, there was 30 or 40% of these kids who probably had some subclinical or occult MAS brewing. And our colleagues in Cincinnati around the exact same time reported on 5 of their systemic JA patients who had labs that were very compelling for a cytokine storm. Hyperferritinemia, elevated IL-2 receptor alpha chain from the CD8 T cells, soluble CD163 from the activated macrophages. And okay, they didn't have MAS, but actually 2 of them went on to develop fulminant MAS. So just because you have subclinical doesn't mean you're out of the woods. And so this concept arose that maybe MAS was part of just the spectrum of disease of systemic JIA. I think a lot of us favor this model here because there are some children who get high fevers, serositis, the rash, who never really develop MAS, but they get sick. They just don't get MAS. And then there are a subset of kids who just get MAS repeatedly over and over and over again. So they're not, it's a little heterogeneous. And that's supported by this data out of Japan, where on a log scale, they compared serum IL-6 to serum IL-18 levels. And when IL-18 was relatively dominant over IL-6, all the children who developed MAS in green were roughly in this half of the graph, suggesting again that these kids are not all the same. So a colleague of mine in Italy, Angelo Ravelli, had done some early work on this, but wanted to get a much more kind of robust diagnostic criteria, because the HLH-O4 criteria, if you waited for that 5th criterion, often your patient may be dead. They just weren't sensitive enough. So we wanted some more specific criteria for systemic GA because we saw it there so frequently. So we asked our colleagues, what are the features, clinical, laboratory, pathologic, that you'd want to include? And then we also asked colleagues from around the world, 95 investigators in 33 countries, to give us data freely, which they did. And this is a big achievement. These may seem like small numbers, but Pete's room is pretty big. And we had data on 362 children with systemic JA who the clinician diagnosed MAS and changed therapy based on that, versus 404 children with systemic JA who were flaring their disease, but they didn't feel like they had MAS, so didn't change therapy based on that. And then hospitalized infectious controls. And from that, we got some of the data you might expect. They almost all had fever, but not everyone. Hepatomegaly was more common than splenomegaly. Lymphadenopathy. These kids have chronic arthritis, but at the time of MAS, many patients actually don't have arthritis, and that's pretty common, but still 2/3 of them did. And usually somewhere between 1/3 and 1/2 of many secondary forms of HLH or MAS will have some kind of central nervous system involvement from mild to severe. And we did a lot of work online, but then we were fortunate enough to get some grants to pay for a meeting in Genoa. We had a choice of Genoa or Birmingham. I like Birmingham, but Genoa was nice. And we had it in this lovely palais. And over a couple days, hammered this out. And we'd had the computer already model about 1,000 combinations of these things with ifs, ands, ors, whatevers. And we came up with this. You had to have a fever and systemic JA. So this was specific for systemic JA, or suspected if it was at diagnosis. And it was a mandatory elevated ferritin. And again, a relatively low threshold here for patients often in the tens or hundreds of thousands. And 2 of the 4 criteria. And if you look at these, most of these cutoffs are at near normal values. So a platelet count of 170,000 would meet this criterion, but that's abnormal in the setting of inflammation. And so we were very proud of our achievement. And this was a combined between worldwide pediatric rheumatologists and pediatric hemato-oncologists. It's a nice effort. Plus, we're happy because we're at this lovely palais in Genoa. And then Grant Schulert went and ruined this to some degree. They're still pretty good, but they're not as good because now treating patients with systemic JA for their disease, IL-1 and IL-6 blockade is really commonly used in certain parts of the world. And so as you can imagine, those things block things like fevers. And so the criteria don't perform as well. And in part because of that, we got a little more reductionist. And we used the same data set as well as some of the data we had on children hospitalized in Birmingham. And what Ezra did was look at this ratio of ferritin in nanograms per ml divided by the erythrocyte sedimentation rate in millimeters per hour. And as you remember, as you get sicker, the ferritin rises. And as the fibrinogen gets consumed in the DIC-like process, the sed rate drops. And so this ratio was pretty good at a cutoff of 21.5 of being relatively sensitive and specific for distinguishing one of the more difficult things we have, which is distinguishing systemic JA flare from systemic JA MAS. And in fact, if you just compared the MAS to hospitalized infections, you only needed a ratio of 11, and you get even a better rock curve here. And then with our patients in Birmingham, if you get even more reductionist, a ferritin alone, when we set the specificity at 95%, was 89% sensitive at identifying MAS. And that, again, at a relatively low cutoff here of 627 nanograms per ml. And in fact, colleagues in Houston had shown similar data a while back. There's some very sick patients here, and these are 20,000 range. But essentially, if you have a fever and a ferritin of 5,000 or 10,000 or more, and you don't have known chronic liver disease or get multiple blood transfusions for thalassemia, for example, you basically have MAS until proven otherwise. And so getting back to the genetics, these funny name proteins, perforin, MUNC18-2, syntaxin 11, et cetera, our colleagues in Europe were looking at their systemic JA population, those with and without MAS. And they found that those with MAS had a much higher carriage rate of heterozygous mutations, specifically in the gene perforin itself, more than those with systemic JA who didn't develop MAS, but that was slightly higher even than the general population, suggesting that even having a heterozygous mutation in some of these perforin pathway genes, including perforin, may put you at risk for developing MAS. And so when I arrived in Birmingham about 14 years ago, myself and Tim Buchanan, who came with me from Philadelphia, we started getting consulted on patients in the hospital with MAS and other cytokine storms, including some of our own patients like systemic JA, but many who were not rheumatology patients. And I was surprised to find early on when we started sending genetics that about 40% of these kids had heterozygous, often multiple heterozygous mutations in these same perforin pathway genes. Many were either unique or rare mutations. Most of them were missense or amino acid changing mutations. And so we hypothesized that, like our colleagues both in Cincinnati who were looking at MUNC13.4 and our colleagues in Europe with perforin, that these mutations may contribute to disease in a more subtle fashion. And so to do that, Mingxi Zhang in the lab made cDNA from RNA from a human natural killer cell line, NK92, and by site-directed mutagenesis would introduce a patient mutation we had identified by sequencing, and then reintroduce. So, and these wild type, the NK92 cells have abundant levels of the normal for all this pathway. They kill perfectly fine. They have all these proteins, but we were giving excess either wild type as a control or empty lentiviral vector as another control, or overexpressing the patient mutation. And we could do this by lentiviral transduction for the smaller cDNAs, or later by foamy-virus for larger cDNAs. And then we could study the NK cell function in the lab. And so for the lentiviral construct, it has this very powerful immediate early CMV promoter, and we could drive expression of cDNA for the wild type gene as a control or the patient mutation. It was linked so we could co-express green fluorescent protein and then sort these cells for analysis. And so I'm going to spend a fair amount on this particular missense mutation in one of these perforin pathway genes, RAB27A. And this was an 18-year-old, previously healthy girl. In fact, she was #2 at the time in the state of Alabama in barrel racing, if you're familiar with that. So healthy individual. But she presented with a couple of weeks of fever and belly pain to the GI service. Eventually, they called me. And when I met her, she was indeed febrile. She had a large liver and spleen. And you could talk to her, but she didn't make any sense. And they were wheeling her to the ICU mostly because her labs were very compelling that something bad was going to happen. And all these underlying ones would have met even the highly restrictive HLA-HL4 criteria. And we had developed a cocktail around this time of using a combination of cyclosporin to dampen the lymphocytes, broad spectrum immunosuppression with glucocorticoids, and the IL-1 receptor antagonist anakinra to treat this. And clinically, she got better within a couple days, as did her hyperferritinemia, her elevated liver enzymes, and her platelets returning back to normal values. And we'll focus on this middle panel, which is a combination of, I think, 8 or 9 experiments. And on the y-axis here, we're looking at cell death of the target cells for the natural killer cells, the K562 cells, and increasing the number of natural killer cells in terms of ratio to the K562 target, so increasing the effector to target ratio. And the NK92 cells, when you just put in the empty lentiviral construct, kill perfectly fine. They do great. Interestingly, and this was kind of initially surprising, if you give them more of the wild type RAB27A, they kill a little bit better. But if you introduce the patient mutation, they don't kill quite as well. It's subtle, but it was real, and that's why we did it so many times. And another even simpler assay, which looks at basically the same process, is during this process of trafficking these cytolytic granules to the hemolytic synapse, they degranulate or put CD107A or LAMP1 out on the cell surface. And it's easy to measure by flow cytometry. So going down the, just based on time, you can see the CD107A expression when we overexpress wild type RAB27A is kind of maximal in this study at about 2 hours. When you put in the patient mutation, it's always lower, and that's kind of summarized here. So about half normal levels of degranulation when you overexpress the patient mutation. A colleague of mine who's much more adept at in silico analyses looked at the previously solved RAB27A structure and its interaction with its binding partners, of which MUC13.4 is one of the ones in that pathway, and predicted that her mutations shown in fuchsia or whatever this color is here would partially disrupt this interaction that was critical for the perforin pathway for RAB27A and MUC13.4. And we showed that by Westerns or by co-immunoprecipitation with controls down here. And you can see that when we overexpressed the patient RAB27A, it didn't interact as well as the wild type RAB27A with MUC13.4 at any of the time points we looked. And we confirmed that by proximity ligation assay. I don't have time to go into the details, but basically this is an assay that allows you to see where two proteins in situ, inside a cell, are close enough to be engaged. And you get these nice little orange dots. Control, we don't have any orange dots. If you overexpress the wild type RAB27A, this is where RAB27A and MUC13.4 are interacting theoretically. And then when you put in the patient mutation, you get orange dots, you just get about half the normal level. So it does seem to partially disrupt this interaction. And then Minksa decided to look by confocal microscopy at this. So E is the effector or the natural killer cell, T the target K562 cell, empty vector control. And here green or yellow is granzyme staining of these cytolytic granules. And you get nice polarization, but not perfect when these NK cells recognize their target cell. If you overexpress the wild type, again, you're getting even better polarization. And then when you overexpress the patient mutation, you get polarization. It's just not nearly as good. And then Minksa, by doing this, had created a ton of work for himself so that he did time course analysis, because that was a snapshot in time. And he did multiple experiments, and he did these different conditions of the empty vector, or expressing the wild type or the patient mutation, and did this in a blinded fashion, so he didn't know what conditions he was looking at. And what he found got summarized in this one graph. So time on the X and percent at the population level of the cells that were polarized when he counted 200 cells per slide. And you can see the empty vector, you get nice polarization, kind of maximizes around 65, 70% here at 1 to 2 hours. The wild type overexpression of RAB27 gets you a little bit higher. But at the population level, when you introduce the patient's mutation, this takes 2 hours to kind of get back to where these other two are. And so around this time, Misty Jenkins and colleagues in Australia had this really nice paper that came out where they took human or mouse cells, didn't matter, NK cells or CD8 T cells, didn't matter, perforin deficient or granzyme deficient, they got the same results. And they looked by time-lapse photography at this interaction of cell death. And what they found was when they were perforin deficient or granzyme deficient, they didn't kill, but they spent 5 times longer engaged with each other. And that resulted in increased gamma, increased TNF, whatever pro-inflammatory cytokines they were studying. So this was like direct demonstration that this defect in killing was leading to inordinate levels of pro-inflammatory cytokines. And so Minksa basically did the same thing, which is summarized here for multiple experiments, where we're looking at percentage of cells producing interferon gamma on the y-axis over time. And the patient mutation, those cells produced more interferon gamma during the prolonged engagement. Now, I had presented this data at a meeting, and a colleague of mine from Rome said, you know, we have a 14-year-old boy with the exact same RAB27A mutation who develops MAS. And they had data on him and his father. Both their patients' fathers had the same mutation and were fine. And the patient and the father, when they were well, had about half normal levels of degranulation compared to the sister and mother who didn't have the mutation, or half normal killing function compared to some healthy controls. And so with all that work for one mutation, for one gene, we concluded that it probably contributed to disease. So even having one bad copy in a partial dominant negative fashion in this pathway may disrupt NK cell function and contribute to cytokine storm. So our colleagues in Cincinnati are very adept at the genetics of MAS and HLH, and they had a systemic JA child who just repeatedly got MAS, and they looked at genes and could never find anything mutated until they looked in the intron of MUNC13.4. And it turns out that the lymphocyte version of MUNC13.4, all these exons, starts at exon 2. And so this region functions as a transcriptional enhancer or promoter. And they did find a single mutation in this one patient in a predicted NF-kappa B binding site. And Grant showed that the splice, this variant that starts at exon 2 in lymphocytes is at about half normal levels compared to a few controls. And we showed in conjunction with them that this was indeed the case. It acted as an enhancer, and this mutation disrupted NF-kappa B, et cetera. So now with whole genome sequencing, it gets more complicated. So it's not just the exons. And this is a model that a lot of us in the field like, myself included, and this is this threshold model of disease. So if you are homozygous deficient in perforin or MUNC13.4, take your pick, whatever, you are going to get HLH. It may happen actually in utero, sometimes within days, weeks, definitely within months of life, usually before age 1, sometimes after that, but you are going to get it, and it may not take much at all to trigger it. Or maybe you have a mild or not so mild heterozygous mutation in the perforin pathway, and you get some of these bad bugs, whether it's bad strains of influenza or leishmaniasis in other parts of the world, and that pushes you over this threshold at which your immune system can no longer balance itself out anymore, and it's just overwhelmed by the pro-inflammatory storm. Or what we see in rheumatology or maybe in oncology with cancer patients, you have some underlying inflammation, like you're a lupus patient and you're systemically inflamed. They often present at onset. You maybe have a heterozygous mutation in one of these proteins, and you get triggered by Epstein-Barr virus or some other infection. And so just because you have the mutation doesn't mean you get the disease, but I think it is a risk factor. So this paper came out in 2010. It caught my attention. It was about the 2009 H1N1 pandemic. And these were pathologists at the University of Michigan who reported on 30, 40 previously healthy 50-year-olds who were dying of the flu. And, you know, we all, we don't all, many of us get exposed to these viruses. Several of us, many of us get these viruses, but very few of us end up in the hospital and or die from these viruses, particularly previously healthy people. So why was this? Well, they reported, the reason this caught my eye is that a large chunk, over 80% of these patients who died had hemophagocytosis all over their pathology. And so I called up Paul, the first author, and brokered a deal through our colleagues in Cincinnati who were doing our genetics at the time. And they had 14 samples that we could look at for genetic mutations. And 36%, and these numbers 30 to 40% often show up in cohorts like this, had mutations in LIST, which is important in that perforin pathway and sorting of granules. And 2 of those 5 also had a heterozygous mutation in perforin 1, again suggesting that these may be risk alleles for developing cytokine storms when you get a bad trigger. So I personally think we're still here in terms of diagnosis. In intensive care, there are multiple acronyms: multi-organ dysfunction syndrome, systemic inflammatory response, and then, you know, the patient who's on their 8th or 9th broad spectrum antibiotic who's dying of DIC, but nothing's helping them and they haven't identified a bug. And I'm not saying all these patients have this, but there are a chunk of these patients who likely would benefit from treating the cytokine storm as well. And so in addition to what we just talked about in the ICU and the rheumatology patients, there are some rare metabolic disorders that can cause this. We talked briefly about cytokine release for cancer patient therapy. There are many, although individually mostly all rare, primary immunodeficiencies, and these kids, Dave can tell you, will develop cytokine storms too, as well as acquired immunodeficiencies, both the virus and some of their secondary complications, infections and cancers. Hematologically, if you talk to your cardiothoracic surgeons, going on the pump or even going on ECMO in the ICU can trigger a cytokine storm. We're identifying a lot more, including autosomal dominant rare autoinflammatory disorders that can lead to cytokine storms. We talked about HLH, and then there's just whole slews of infections, including things like dengue and Ebola that can cause these as well. Okay, treatment. So how do we treat? I'm going to focus on the the more targeted approaches today. So in addition to that very first patient we told you about, Ed and I contributed a couple patients to this series that Päivi Matunen put together with their colleagues in Calgary. And these were kids, mostly systemic JA, but some other kids with vasculitis, who were failing high-dose steroids. Intravenous immunoglobulin is often used. I don't find it all that helpful, but it's not harmful. Cyclosporin, a couple of kids getting etoposide and just not getting better. And they all got better with, at the time, what I would consider relatively low-dose anakinra. So that was encouraging. We've reported more recently, just on our cohort of kids in Birmingham over a decade or so, 44 kids who at some point, and to be fair, we included even a couple of kids who got anakinra kind of as a last ditch effort in the last few days of their life, even though they'd been sick for over a month, for example. But nevertheless, the mortality was about, it was 27%. And that is better than the etoposide mortality for secondary HLH, which is around 45%. Nevertheless, kids still can die despite giving them anakinra. But we learned some important things from this study. One is thrombocytopenia is bad, either at initial measurement or at any time during the hospitalization. Thrombocytopenia was a bad prognosticator, as was having 2 or more cell lines down based on the H-score criteria. And interestingly, again, over 30% of these kids had mutations in HLH pathway genes, heterozygous mutations, particularly if you had STXBP2. 4 of those 5 children died. So that may be a relatively bad player when you have a het mutation. The good news was the earlier you started anakinra, the better. Yay. And all the kids with systemic GA, I think there were 13 in this cohort, survived, either because IL-1 is really important in that process, or we just recognized it earlier because we knew these kids. So for me, I look at this relatively simply in terms of the IL-1 story. Anakinra is a recombinant human interleukin-1 receptor antagonist, and it blocks the ability of both interleukin-1 alpha and beta to interact and signal through the IL-1 receptor. And at some point, this just outweighs the amount that your own body is making, and you give them more. It's that simple. I really like this drug for a lot of reasons, and here are some. So it's recombinant. So not that you can give endless amounts of insulin to people, but here you're really just blocking excess IL-1. And we have a lot of safety data. It was going to be a good drug for RA, not so much, but we have a lot of patient safety data from that data. It's very fast acting. So if you're not getting benefit from it within 2 to 3 days, you can just stop. And it's gone because its half-life is very short. So even if it was dangerous, which is not, it's gone before you know it. If IL-1 alpha is important, usually IL-1 beta is the bad inflammasome player here, but IL-1 alpha, including in COVID, may be important. The antibodies aren't going to touch that. It's got a ginormous therapeutic window. There's very few drugs you can 20 times the normal dose and get more benefit without more side effect. And in parts of the world like 2014, when Ebola killed a lot of people in Western Africa, part of the reason many of those patients died is it was so remote that they couldn't even get IV access for many of those patients. So it can be given subcutaneously as well. Beta Shakuri contacted Charles Dinarello and Stephen Opel. So our intensivists and infectious disease docs, they realized that many of their patients with frank sepsis, and this is important to point out that cytokine storm is not a diagnosis of exclusion. So you can have sepsis, you can have leukemia, you can have lupus, and you can have a cytokine storm on top of that. You have to treat both. Anyway, a subset of patients who develop sepsis get cytokine storms. And so our colleagues back in the late 80s, early 90s were studying blocking TNF, blocking IL-1. And this was kind of the penultimate IL-1 study, over 1,000 patients with sepsis and identified organisms. About 30% mortality whether they got placebo or anakinra. I mean, virtually completely overlapping curves. Didn't help, didn't hurt. And they were using mega doses of anakinra here. But what Beta did was she got the data, and where she could collect it, and using the intensivist definition of hepatobiliary dysfunction and DIC, those patients, the mortality if they got placebo was 65%, but if they got IL-1 blockade was only 35%, suggesting again that there are subsets of patients who are septic who may benefit from treating the cytokine storm. Before COVID hit, Dr. Chatham, one of my rheumatology colleagues at UAB, and I started a clinical trial of anakinra for secondary forms of cytokine storm syndrome. And as part of that, we collaborated with Hudson Alpha and Devin Absher doing whole genome sequencing. These were the first 5 patients enrolled. it isn't 30 or 40%, this is everybody, had some kind of heterozygous mutation, often multiple ones, mostly missense again in these perforin pathway genes. This is shocking to me. We did a few more patients and also picked up this protein DOC8. And DOC8 is a GTPase that interacts with a variety of proteins, including CDC42, which has recently been identified as a cytokine storm syndrome gene. And it's important for actin cytoskeleton reorganization. So indirectly, it affects the perforin pathway and the trafficking of cytolytic granules. So it's not a direct hit, but it does affect that pathway. And so we now have 16 patients we've identified, not just here, but elsewhere, who have DOC8 heterozygous mutations. Again, the bulk of them are missense or amino acid changes, mostly rare or novel. One of these patients' mutations, Minksa did the same studies we did, I showed you with RAB27A. The killing, when you give the patient mutation, is less, the ability of these NK cells to kill, as is their degranulation. And at the same time, in vitro, they're overexpressing TNF and interferon gamma for the lack of ability to kill, as well as the wild type. One of these mutations was a splice site acceptor variant. And my son needed a high school project. And so he worked on this with Minksa. And we ultimately ended up developing our own assay and confirmed it with the traditional exon trapping assay, but we were running out of time. So what we did was we took a plasma that expressed this green fluorescent protein and cut the cDNA as if it was two separate exons, introduced the patient's or the wild type intron sequence with the splice site acceptor variant. And the wild type sequence, we got, compared to the parent plasmid, pretty good expression. So GFP, the intron was being spliced out, but with the patient mutation, it wasn't. So kind of a hypomorphic effect here. And then more recently, we've collaborated with Ed Behrens, who is adept at mouse models of cytokine storms. And he got the DOC8 knockout mice and infected them like Michael Jordan did with LCMV. And they don't get as severe disease as the perforin knockout mice, for example, but they are different. So they continue to lose weight compared to the wild type mice who start to recover. They have more significant splenomegaly. They have more severe thrombocytopenia, elevated levels of interferon gamma, and more liver pathology. So again, it's not as direct as perforin, but it's likely to be involved in that. So we think it probably fits somewhere in here. There are these primary immunodeficiencies, autoinflammatory. So we're getting a lot of genes here that may contribute to this. And a lot of different pathways, whether it's cardiac bypass, these rare metabolic disorders, autoinflammatory diseases where IL-18 may be really important, these genetic ones, both the homozygous and potentially the heterozygous, CAR T-cell therapy and cytokine release, and then a whole slew of infections, including maybe SARS-CoV-2. IL-6 blockade is great for cytokine release, as is IL-1 blockade. About 20 to 30% of patients who get this therapy for refractory leukemia will develop this cytokine storm, but you can treat it. Emapalumab, so it's come full circle for Michael Jordan. So anti-interferon gamma is now FDA approved to treat the familial, the genetic form, which is a lot safer than etoposide. But it's also now another option that's being studied in secondary forms. Janus kinase inhibitors, which will inhibit multiple cytokines at once because these are signaling downstream of receptors that bind multiple cytokines and share similar signaling molecules. So these are getting studied as well. So corticosteroids are still fabulous drugs. So if you're worried about infections and other things, you may not go to them initially, although they work really well. And you may just want to start with IL-1 blockade, but we're getting a lot more options here. You can see the ones listed. And COVID. So this was about a year and a half ago when Shadow and I were, and I imagine many, many others, were reading the reports coming out of China on the severely ill patients. And we realized that a lot of these patients, not identical, but had similar features to cytokine storm syndromes. And maybe they would benefit from some of the treatments that we just went over. And could we prevent this severe progression that some patients developed? Maybe up to 20% would be sick enough, right? And send them down this pathway if we hit them at the right time point, not during the viral crazy phase, but during the immune response phase. And so the one thing that came out of all these studies so far is that the one thing that seemed to actually help survival are glucocorticoids. They're not a home run, but they're better than anything else that's out there so far that I've seen. But it's particularly important that you give it in those who need it. Like, so not people at home and not people who don't have even oxygen requirements, because they may actually fare slightly worse. But it's mostly a timing thing at what stage of the disease you're treating this. So glucocorticoids can save lives. IL-6 blockade studies have been all over the map, but in general, the meta-analyses do suggest that in the sickest of the sick, they probably help survival. There are a lot of retrospective case series that suggest that blocking other pro-inflammatory cytokines, whether it's GM-CSF, or now there's some actually pretty good data for some of these Janus kinase inhibitors actually improving survival in COVID patients, severe COVID patients. And IL-1 blockade, I think, based on many of the papers I reviewed, I think eventually will be helpful for some patients as well. And in fact, Dr. Chapman and I did a small, very small study here at UAB. Although Anna Kinder started the blue line helping, this is survival here, at the end of the day, the survival was pretty bad, and that we chose really, really sick patients. But I do think, based on reading much larger studies than this small study, but the one thing I wanted to point out is that 30% of these patients, again, had primary HLH mutations, and another 20% had NOC8 mutations. So the genetics is fascinating. And so this is where we've come to, right? So cytokine storm syndrome didn't get a lot of attention for a long time. Etoposide was first reported to be used in the mid-80s. The first gene, perforin, that was associated with this wasn't reported till 1999. That first case I presented to you, where anakinra was first time used for MAS, was 2006, I think, got published. But we now have FDA-approved tocilizumab for cytokine release syndrome as part of CAR T-cell therapy, and emapalumab for primary HLH, so blocking interferon gamma, and then COVID. And if there's one message, if you remember one thing today, anywhere on the planet, child or adult, and there's about 4 times as many patients than adults, because there's about 4 times as many adults as there are kids. If you are sick enough to be hospitalized and you have a fever, please get a serum ferritin. It's cheap, it's easy, it's usually fast turnaround. If it's high, start working them up. If it was me, I'd start giving them anakinra. But if it's low, okay, you feel okay maybe, and maybe check it again later. But the earlier you treat, the better they're going to do. It's a pretty cheap test. We've gotten it on our sepsis protocols here at Children's. It took over 10 years for me to get that done, but it's now there. And it's helped actually to identify patients early on. And I think that's it.
Dr. Cron, thank you so much for that. A lot of great stuff. I like your slide here at the end. We have anybody have any questions? Please, of course, put them up and ask them. And Dr. Lewis, you can turn your video back on too if you'd like.
Okay.
Dr. Lewis, would you like to kick us off with any questions, discussion for Dr. Cron?
Sure. Can you hear me? I think. Yeah. All right.
Man.
So thank you, Randy. That was it truly was a whirlwind. One question I have for those of us that are trying to do, translational lab work to help patients is, are there any changes in the assays you're doing because of the CRISPR technology that might, allow us to more quickly assess, a variant in terms of these mutations in the cytolytic pathway? I know Beth Martin and I have to review many adult cases where we identify things by sequencing, but really don't have an easy way to kind of go forward with assuming, whether it's a variant of significance or not. So what are your suggestions for us in the trenches?
Unfortunately, I don't have a great answer for you. It's still really kind of brute force at this point. We have used CRISPR for DOC8, for example, in NK92 cells. And you can completely obliterate DOC8 and they still kill, but it's about half normal. So again, it's not as critical as knocking out perforin or MUC13.4, for example. Unfortunately, we have been unable to clone those cells after using CRISPR-Cas. I don't know why. It's a technical challenge more than anything. So every time we have to do this studies, we have to do them over and over and over again, which gets a little painful. But I don't have a simple answer for you at this point. And the algorithms that you get back from companies like Invitae or whatever that say, you know, this may or may not be pathogenic, until you test them, you just don't know.
Okay, I'm going to then ask a question from Bob Siegel about should we be doing a genetic analysis for some of these heterozygous defects, and just sort of in general, what about the use of IL-1 inhibitors in patients that have, you know, again, this would be patients that often have HLH in adults where we don't you know, have a specific trigger in many cases, but they have recurrent disease. Sort of how do you manage it? You know, should we be doing whole genome sequencing on more and more patients since it's becoming, you know, I would add that since it's becoming commercially available, CLIA approved, and the costs are coming down. Yeah,
I mean, you get into a whole lot of crazy issues when you start talking about this. I mean, at some point, maybe, if you know, we don't bring up the Book of Revelations or something, it may be that when you're born, you get whole genome sequencing, right? But what do you do with all that data? You know, you have to know what's important and what's not. I mean, I'm all for data, so we sequence as many patients as we can, but this is where I live. So, you know, if you get a patient who, certainly patients who get recurrent cytokine storms, I would definitely do genetics. I will say though, that like that 18-year-old with Rab27A, I recently saw her. She's now a mama, and she came to see me with her son because she was worried that maybe her son would get it, and she's perfectly fine. So, you know, I do think it is a risk factor, but it doesn't mean you're going to get it over and over again. So I certainly wouldn't transplant her. Now, there are some patients who show up really late in life who actually have homozygous defects that do get transplanted. So I'm always a fan of more data. So if you can get it done without patient cost, then I think it is valuable. You can't, you know, you do have to have genetic counseling to some degree because you can't necessarily tell them exactly what it means at that point, but it may guide your thinking. I'm always a fan of data. I think more data is better than not. In terms of anakinra, yeah, you know, it's not a perfect drug, but it's safe, it works, and if it doesn't work, you know, you haven't lost much, maybe a couple days of maybe potentially trying something else. But boy, it's a remarkably safe drug. It's a remarkably effective drug. It's got a high therapeutic window, and it works for a lot of conditions. We've even, through colleagues, treated cancer patients. We've even treated a familial, not we, but a colleague of mine had treated a familial HLH child who they didn't know was familial HLH, who got COVID and got anakinra alone, got over the COVID. They did the sequencing, found a homozygous STX11 disruption, and then the kid got MISC and they treated him again with anakinra. That was it. So, I mean, that's one kid, but it's a remarkably effective drug. And as much as I think of myself as a scientist in the lab, as a clinician for these rare things or things we just don't have true data to guide us, I'm very much a doctor of anecdote. And again, you got to weigh your benefits and side effects like everything. And the potential benefit to side effect ratio of anakinra to me is very high.
Fair enough. You know, the other thing that I wanted to ask you about was, what do you think is distinguishing, what should we be considering in terms of pathophysiology between classic MAS that you see, for example, in rheumatologic diseases, and secondary HLH from infections? Can you make a kind of clinical distinction between those two and how you would treat them? And I would particularly, you know, want to suggest that, you know, for some diseases, more T cell targeted therapy might be helpful as opposed to just, you know, more anakinra focus. Can we make that kind of distinction or nuance, do you think?
Again, I'll go back to anecdote, but the other thing I'll say is if you got an infection, if you know what the infection is, and we're getting pretty good now at identifying bugs by a variety of techniques, right? Even viruses, we're getting pretty good at identifying by a variety of methodologies. You got to treat the infection. And sometimes just treating the infection will get rid of the cytokine storm. So number one, that's an important piece. It's not really your question, but if you have an infection that's triggering it, and that includes a lot of our lupus patients and even some of our systemic JA patients get triggered by infections, not just an auto-inflammatory process. Treat the infection too. But in terms of whether you target T cells and some types or others, I can't really say. I do think in general, the earlier you treat with whatever it is, the better your outcome is going to be. And we use less cyclosporin than we used to because we can sometimes just get away with anakinra alone for many of these patients. That in combination ultimately with steroids. For H1N1, steroids seem to be really again, it's anecdotal. We're talking handfuls of kids here who got severely ill with H1N1 recently. Not back then, but even just a couple of years ago. Steroids are really helpful there. But and they're just broad guns. So I don't have a precision medicine answer for you, Dave.
Yeah, I think it comes up a lot with the treatment of the potential familial HLH patients. So, do you feel though that a trial with anakinra as an early drug, maybe in combination with T cell targeted therapy other than etoposide, is something that we should be doing?
I think for familial, I think the data is pretty compelling, and anecdotally what we've experienced here, and it's not my patients, but I'm sometimes involved peripherally in their care, is emapalumab. It's a great drug.
Yeah.
It seems a lot safer than etoposide.
Okay. Do we have any other questions from the floor? Let's see.
Dr. Lewis, we have one more question, or perhaps from Leland Shapiro. Do you want to field that one? And then after that, it's 9:03.
Yeah, sure. So this is coming from Leland, who's a skeptic of the cytokine storm concept in general, and that the serum levels of IL-1 are low to undetectable in all the diseases discussed. So you may want to talk about why that is a problem for detecting IL-1 in disease in general. So what exactly is anakinra supposed to be blocking? I saw no slides showing levels of the storm. And also better designed studies in COVID-19 show anakinra failed to benefit patients, and anakinra has repeatedly failed in sepsis. So he's coming at it from a skeptical point of view, but you may want to first address the difficulty of monitoring IL-1 in general biologically.
It's very hard to measure. It's got a short half-life too, and it's just plus we don't know what's going on in the tissues. So granted, you're right. If the definition of a cytokine storm is measuring high levels of every single cytokine that we're looking at, that may not be the case. But anecdotally, it works. Even the reason that they blocked IL-6 initially in Philadelphia for CAR T cell cytokine release syndrome was because they could measure IL-6, and it was high. But it turns out actually that IL-1 blockade, particularly even in mouse models of CAR T cell therapy, works even better. But again, you can't measure it that well. So just because you can't measure it doesn't mean it's not part of the process. But it is difficult to measure. So some people will do things like measuring associated genes, but that's not practical for most people. So I personally don't even measure cytokine levels other than things like IL-18. I'll call up Scott Canna, for example, if we're worried about an rare auto-inflammatory kid. CXCL9 is an indirect marker because again, gamma interference is not so easy to measure. So there are other ways around it. But I think again, just from papers I've reviewed, I think there will be some benefit of anakinra in COVID. And like I said, the IL-6 data was all over the map, but it's complicated. And I agree that COVID-19 is a relatively unique cytokine storm compared to all the others. And it may not be a cytokine storm, but it's a hyperinflammatory syndrome for sure.
Yeah, I think we're probably going to have to end, but I would also, think that perhaps IL-1 receptor antagonists may actually be useful in my limited experience with trying to come up with another marker that I think actually is coincident with, it's a pretty good indicator of IL-1 beta disease, in my limited experience with it. So, well, I think I want to thank everybody for this wonderful Grand Rounds and presentation by Randy, and really appreciate your spending the time with us today, and hope we can interact on these and interesting other clinical issues. I know there's a lot of interest in dealing with hyperinflammation, both on the adult and pediatric side at Stanford. We have a lot of it just like you do, but unfortunately, I think Alabama is going to get probably more COVID-19 resurgence than we are, but I'm sure we're going to get some. So thanks, Randy.
All right, thanks for having me.
Yeah, on behalf of the department, Dr. Lewis, thank you for hosting. Dr. Cron, thank you so much for being with us, and thanks to both of you for everything you do in this field and related. So thanks again. And for the attendees who are still with us past 9:07, thank you for sticking around. Hope everybody has a great week, and we'll see you next week.